Good afternoon, everyone, and welcome to the webinar on alternative and innovative approaches to COVID. Yeah, as you all know, India has and India is a few weeks behind China, Europe, and US in terms of where we stand in terms of COVID. So I think this gives us an opportunity to learn a lot, and also we have to be very conscious that the healthcare systems of those other economies are not similar to what India has in terms of the population we have, in terms of the infrastructure we have, in terms of the training of personnel. So given this, we have Dr. Dileep Raman. He is the co-founder and director of Cloudphysician, who will be talking to us about some of the approaches that they have been recommending for use should hospitals be called upon to respond to COVID-19 situation, and should there be a resource constraint environment. Dr. Dileep Raman is a pulmonologist and an intensivist who trained and worked in the US. He and his co-founder Dhruv Joshi came back to India to start Cloudphysician. This is a remote ICU monitoring startup based out of Bangalore. Dileep, thank you so much for your time, and welcome to the webinar. This webinar is first of the series that ISB will be conducting directed towards COVID-19 preparedness, and thank you for joining in. Can I start off by saying what have been the lessons? What are the lessons that we probably can learn from other countries in terms of COVID, and what are some of the things that India should take into consideration when we respond to an escalated situation?
Yeah. Good afternoon, everyone. Thank you, Soumya, for the intro. Happy to be here, and thanks for having me. Just to clarify, our aim of this webinar, from my perspective, and from what the topic says, is we're going to be focusing mainly on the critically ill segment of the COVID-19 patients, the ones that get admitted and in the ICU. That is what our expertise is, primarily in intensive care. There are other problems that India and other countries are facing from the population level standpoint, where containment, case finding, isolation, quarantine, and so on and so forth are also going to be critical pieces of this entire puzzle. So you will need infectious disease experts, epidemiologists to solve this puzzle, but we are approaching this purely from the inpatient ICU standpoint. So in that regard, lessons from the world and how we can learn from them are very important, because we are a few weeks behind some of the other countries, and we may see a spike in the numbers as the weeks go by. And what this gives us is an opportunity to plan and see what we can analyze from what's happening in the rest of the world. One of the important things is that we do know that about 75% of those who get admitted to the hospital will require only minimal supportive care. They don't need to come to the ICU. And what we do know about the remaining 25% is that they get very, very ill and quite sick in the ICU, and some of them unfortunately do end up dying. With these facts in mind, we have an opportunity to plan, get our resources in order, and handle this ICU/inpatient problem in a fairly logical and algorithmic way. We have seen different constraints in different countries. Some are dealing with problems related to ICU medications, ICU equipment, protective equipment. Others are dealing with mundane issues which seem mundane, like oxygen. Oxygen is actually a critical piece of the entire puzzle, entire treatment pathway. But we hope that it gets more and more focus in India, because frankly, some of the resources that the Western countries have at their disposal We may not have that in low to medium economic settings across India. So those are some important lessons that we need to garner early on and prepare our hospitals for this oncoming surge. That said, there are a lot of theories that maybe we'll not have as much of a surge as has been seen in the West due to various factors. And all these theories to some extent are unproven, like the temperature theory or maybe the TB vaccine that our population has given. Maybe that will blunt the numbers a little bit. All that considered, the numbers in India, the denominator, our population is so big that even if these factors offset things a little bit, we may still see a lot of patients that will saturate our capacity. And that capacity is something that is worrisome to all the ICU doctors and nurses and ICU personnel and the allied staff, that we kind of know that this shortage might be put to strain. And that stress test is what we need to be prepared for. Is your audio functional?
Yes, sorry, I was just figuring out how to unmute this. So thanks, Dileep. So yes, unlimited expansion of resources is not possible. So can you talk about the specific recommendations that you have made in the paper that you and Dhruv have written about some of the frugal innovations that India can do that can expand treatment capacity?
Right. So that's where we think we can take some of the lessons from the West, yet adopt it in our own way so that we can help the maximum number of patients with the resources we have. So an example is the government has been pushed to increase the supply of personal protective equipment, PPE. Lots of innovation happening there, a lot of engineering teams looking at low-cost ways to generate PPEs. And that was one of the first points we mentioned because it's critically important. You cannot have an unprotected healthcare workforce taking care of COVID patients because that healthcare workforce is finite. We cannot replicate workforce like we can say replicate personal protective equipment or manufacture devices for ICU patients. That constraint in mind, the other problem that we wanted major government organizations and maybe even the private sector to look at is oxygen. Because these two things need to be solved at scale. And once you have these two in place, the rest of the care of a COVID patient in the ward or the ICU setting is largely supported. And from a population level standpoint, these two things need to be addressed very strongly. We are also seeing a lot of focus on designing ventilators and seeing if low-cost ventilators are an option for patients with COVID. As ICU doctors and from what we have looked at in the West, these patients that end up requiring mechanical ventilation or go on a ventilator actually need to be on a fairly advanced ventilator. What we are finding out and learning from them is that these ventilators are very capable devices. And patients who are really sick with advanced coronavirus-related lung disease end up needing a lot of support with time-tested, rugged, and robust devices. While ventilator production and ventilator innovation must continue, we may need them eventually. We need to be cautious in understanding that these low-cost ventilators that we are going to develop quickly may not meet all the safety criteria that are vital and critical for these patients. Just to illustrate an example, when you have a patient on a ventilator, there are a lot of things that a ventilator can do that can potentially harm the patient. So a ventilator doesn't cure the patient of respiratory failure, it merely buys you time to treat the underlying respiratory failure. So there is something known as ventilator-induced lung injury, and this is a common problem worldwide. It's been known in the scientific literature for decades. Our ventilators that we are re-engineering need to be matching a preset requirement that ventilator-induced lung injury can be avoided. Another thing that is well known in the ICU circles is something called ventilator-associated pneumonia, which is an infection that comes through because of ventilators. For these reasons and many more, you can't just design a high-tech ICU device. A ventilator is just an example, but there are many such devices without the appropriate supervision, without the appropriate skill needed to handle these ventilators. Because it seems like there is always a signal of harm that is possible here. So what we are working with a lot of amazing engineering teams, for example, with IIT Kanpur and others, is that we also need to look at solutions that help 80% of the patients that are not going to need ventilators, because that is also going to be a vital chunk of these patients that come to COVID treatment units. For example, they may need a lot of oxygen, and oxygen can be delivered, in a cost-effective fashion with high-flow nasal cannula devices. High-flow nasal cannula devices right now are manufactured by 3 or 4 companies that actually make these devices that are still quite expensive. But they're easier to re-engineer and easier to deploy in India compared to the amount of know-how and technical skill required for a ventilator. So what we're trying to do is talking to these engineering teams who are already doing amazing work with ventilators that needs to continue. But we also need to refocus some of our energies towards these lower cost solutions that can help a larger number of patients and a larger fraction of patients. Again, one of the learnings that we had from the West and from China is that when you have severe disease in the ICU and you're on a ventilator, there's a good chance that 50 to 80% of these patients may actually die, no matter what you do. So the idea is to think about this from a pandemic scale. So as doctors, we're exceptionally well trained at looking at a one patient, one-to-one perspective. And that's great for a traditional situation where one doctor is dealing with a smaller number of patients. But when you're at a pandemic scale, your thinking needs to be more exponential. We need to sit together and find out how we can affect this change at a larger population level. And then we can look at how much resources to deploy in which sections, which may be more meaningful. So another example that you would have seen is the ventilator splitting device. Now, if you're in a highly functional ICU with highly trained ICU doctors, nurses, and respiratory therapists, you can use that splitter to take care of more than one patient. But the unfortunate thing here is that if you give that splitter to a hospital that does not have an ICU specialist or a lung specialist, you are likely to do harm when you connect multiple patients to a single ventilator. So some of these insights are really important for us to plan how we deploy our innovations. They may be low cost, but they also need to be low harm. So low cost innovations does not always mean low harm. And we need to rethink some of these things so that when we do hit the peak of the epidemic, we are prepared for these scenarios. Another thing that has come into play is if you look at the guidelines from the West, we had to re-engineer some of that. And one of the important things was this push towards negative pressure rooms. So the earlier guidelines said that avoid the use of high-flow nasal cannulas, go straight for a mechanical ventilation, which is when a patient is on a breathing machine with the tube in their throat helping them breathe. When this happens, a lot of infectious particles may be generated, and these infectious particles may put the healthcare workers at risk. So the recommendation was that you want a negative pressure room where the infectious air is sucked out, filtered, and recirculated. Now, frankly, that is just not possible at scale in India. So in India, most hospitals may have 1, 2, you can count these negative pressure rooms on your fingertips, very few. And to scale them up quickly in a couple of weeks is really an impossible task right now. So if we were to look at this from a scale problem, we went back and looked at the WHO guidelines. We took some lessons from the 1918 Spanish flu epidemic. So in the 1918 Spanish flu epidemic, most of these patients were treated in an open air setting, using the benefits of natural ventilation to take care of these infectious aerosols or droplets that are generated, and to reduce the risk of healthcare personnel being subjected to these airborne particles known as aerosols. The good thing about the Indian setting is that we live in a temperate climate. And yes, there may be some temperature-related discomfort when you're using personal protective equipment. But if you use natural ventilation in the way that the WHO guidelines suggest, you could do without negative pressure rooms that are an extremely high cost infrastructural requirement. So what we would suggest is if you're setting up a COVID treatment unit where 75% of these low acuity patients are going to be treated, just use natural ventilation, augmented with fans and exhaust systems that can increase the flow rate to keep the infectious aerosols at a low level, thereby protecting the healthcare workers. And we specifically put this out in the paper, and we are thankful that the newest guideline that the ministry has put out actually does recommend high flow nasal cannulas and recommends and suggests to use natural ventilation to help with this cleaning of the air and making sure that the recirculated air is avoided, because a bulk of the ICUs in India are using either split ACs or central air conditioning that does not have high efficiency particle filtering that is required to protect the hospital environment from viral droplets and viral aerosols. So again, Western guidelines can ask for perfect scenarios, but unfortunately they don't exist. So I would urge hospital administrators, ICU doctors, and people who are managing the wards to really look at this from an Indian-centric perspective. And now we have the guidelines that can actually back us up and can support us in making these cost-effective recommendations. So open-air ICUs, high-flow nasal cannula, in the perfect setting, they may not be optimal, but in the Indian context, to save the maximum number of lives, given the resources we have, I think that is the way to go, and probably what we should be focusing on.
Great, thank you so much, Dileep. And I think you referred in your conversation here about lack of highly trained personnel, right? So should there be a situation where highly trained intensivists or people who are trained to handle ventilators are asked to come and be asked to respond to the situation? What would be some of the recommendations that you would have? And of course, for the benefit of the audience, these are recommendations, and all treatment protocols and should be run through the required process within your hospitals and healthcare organizations. These are, of course, just views that Dileep and Cloudphysicians are giving out so that you can have a very informed discussion about the options that could be available to you. So, Dileep, over to you.
Yeah, that's right. I mean, just to reiterate that, like I mentioned, the Government of India has guidelines. There are a lot of international guidelines. The Society of Critical Care Medicine has put out international guidelines, and Bangalore's the Bangalore chapter of ISCCM, which is the Indian Society of Critical Care Medicine, has also looked at these from a very pragmatic view. So your hospital leadership, they may include an infectious disease doctor, an anesthesiologist, an ICU specialist, infection control. All these teams would need to come together and look at it from a multidisciplinary angle. What we are looking at is that while we have all this focus on the devices, one of the things that is concerning is these newly designed ventilators, the newly designed devices will still need to be managed, will still need skilled manpower to make sure that these devices are doing what they're supposed to do, which is taking care of patients and saving lives. And just to put things in perspective, there are only about 4,500 trained ICU doctors in India. Critical care nursing is in short supply. And another thing that is often not discussed and is being increasingly recognized is that there are only a few thousand dialysis machines in India and about 2,000 kidney doctors, which is nephrologists. The reason why I bring this up is that about 1/3 of patients with really bad COVID disease will also end up needing dialysis. Now, we talk about oxygen, we talk about personal protective equipment. This is going to be an important problem when we look at this problem at scale. So India has about 1.5 lakh people who need routine dialysis. They have kidney disease, they need dialysis. If you plug in the COVID-related dialysis numbers into the hospital, that's another problem that we're going to have to deal with. That is there. So you're going to have all these collateral damages that are going to be offshoots of COVID that are less discussed. So we may face a dialysis crunch, and we may have patients who need dialysis and are not able to get it. Another problem statement would be all the paraphernalia in the ICU that is needed to manage an ICU patient will be in short supply. So for example, when you put a patient on a ventilator, on a breathing machine, you need to sedate them. You need to make them comfortable so that they can tolerate this foreign object that is trying to help them breathe. That doesn't come naturally. You have to give pain medicines, you have to give sedatives. And again, lessons from the US and other areas is this is in short supply. People are running out of sedatives for ICU patients. And this is an absolutely terrifying and telling warning for us, because if that happens, you can design the best ventilator in the market. But if you cannot sedate the patient, you are going to cause more harm. So this ties into skill as well. You can have skilled personnel and the device, but if you don't have these neighborhood devices, if you don't have these medications, testing facilities, you're not going to be able to effect care at scale, because all these things go into taking care of an ICU patient rather than just these high-profile focused devices. So another example that's coming up is the shortage of blood. We've heard in the news in Bangalore itself that military personnel are offering their services voluntarily to donate blood because of lockdown and because of the crunch that's coming. There isn't enough blood in blood banks. And you look at UK data and US data, many of these patients who come with COVID actually have low blood counts. So you are going to see problems that haven't been talked about because either there's a lack of focus, or the focus is there and there are just so many problems that we're not able to handle and deal with them, every single one of them, to make sure that these ICU patients get the care that they deserve. So another message to hospital administrators and senior doctors and nurses and people who are in the procurement cycle is to look at these adjuncts that are needed. Even, for example, the UK has suggested second-line medications that can be used when these medications are in short supply. So you will need skilled people to inform you that these supply chain issues are coming. So that's again where an ICU expert and an infectious disease expert will come into play to suggest these things and these modalities that are important from a supply chain perspective. Now, back to the skill question, it's looking more and more like you're going to need a force multiplier. You're going to need to use a tool that enhances the capacity and the capability of your personnel to help as many patients as possible. So the government of India, again in its foresight, has actually quickly acted upon telemedicine guidelines, reframed them and put them out for the public so that it can be utilized to take care of multiple patients given the current crunch that we have in personnel. So tele-triage, for example, is an important way to reduce the influx into the hospital. So I told you that the number of patients who get to the hospital are about 20% of the entire people who get sick. So that means 80% of COVID patients can be managed as an outpatient, either at home or with home isolation. And telehealth, telemedicine, both from an outpatient angle and from a triage angle, is going to be vital, because you have these resources that are already strained. You have maybe 1.5 lakh ICU beds. You want to secure them, keep them as safe as possible. And one way to do that is to keep patients outside the hospital. And teletriage goes a long way in doing that. And there are many startups that are working together on this mission. In fact, Karnataka now has a helpline that was put together by the startup community, and this helpline connects the patients who are at home to the doctors via telephone and helps them walk through their problems and assures them to seek care if required, but also gives them a framework to stay at home if they can. Many private enterprises have set up telehealth and teletriage facilities where their patients can log in, talk to their doctor online on a video chat, and hopefully stay at home. That can again be applied in the inpatient setting as well, where a single doctor can handle more number of patients in a COVID treatment unit if the crunch arises. To give you an example, an average ICU doctor, which is our expertise, is able to see maybe 10 to 15 patients in the ICU per day. That's what a traditional ICU rounds looks like. In the West, again, there are tele ICU systems where one doctor can help manage 160 patients using a tele ICU network. That is the kind of frugal innovation that you need in India to make sure that these critically ill patients can receive the equitable healthcare that they need at a moment's notice. So these systems will need to be redeployed in the Indian setting, where the expertise of an ICU doctor can be leveraged by the ground team to make sure that these quality metrics that an ICU patient needs are best utilized. So another thing that we need to focus on here is something called despecialization. So despecialization is an interesting concept and something that we are hearing about more and more, but I think it's going to be vital to understand, is that you are going to have neurologists, cardiologists, gynecologists, dermatologists, who are all trained in medicine but have specialized over the last few years into their area of expertise. If we are in a crunch and we need to take care of COVID patients, you are going to have specialists who despecialize and learn a little bit more about COVID and use the intensive care, pulmonology, and infectious disease expertise via telemedicine or Tele ICU services, so that they can be part of this workforce that can help take care of COVID patients. So again, if you're part of a hospital administration or leading a clinical team, put out material, teaching material that you can use to help your clinicians, both nurses, doctors, and respiratory therapists, to despecialize and just get trained and focused on COVID, so that they can do all the basics right. And when it comes to the expert opinion, they can get the expert opinion through telemedicine, using the intensivists and the pulmonologists who can actually help take care of these patients, and help the ground team effect higher quality and better care that would not have otherwise been possible. So that change in the ratio of specialist to patient is where technology really comes. Remote monitoring solutions can also help the nurses monitor the patients outside these wards, so that the nurses and the trainees and the postgraduate medical students who are taking care of these patients are not exposed to these patients as much as they would be without technology. So you can imagine that a technology solution that remotely monitors 15 to 20 COVID patients can be placed inside the COVID unit, and the nurses and the doctors can monitor them at outside. We are already doing this in some of our hospitals, and it is the perfect way to rationally use your healthcare resources, keep them safe, and also keep the COVID patients from infecting other non-COVID patients in these health facilities. So absolutely need of the hour to leverage technology in any way you can, in every way possible, so that you can minimize the potential for harm across your hospital unit. Because once you lose a healthcare worker, that healthcare worker is gone for the quarantine period. And that's a finite resource. And again, Italy, US, UK, all these places have faced that crunch. We cannot let India and the Indian healthcare setting to be strained by this avoidable problem. So while we need personal protective equipment, let's focus on how technology can actually help act as a force multiplier and make sure that these approaches are put in place before the actual shortage and the potential for this problem really gets hard to handle. I can't hear you. I think you're mute.
Sorry. So, yeah, thanks. Thanks, Dileep. I think we will throw the room open for some questions. I'm sure there will be. So, participants, there is a small window for chat here. So go and plug in your question, and then we will take questions as they come in. Please go ahead.
I think you're mute, Soumya.
Yeah, no, I'm just.
Oh, okay.
So we have a question here. We have a startup that has a remote monitoring solution. Would love to understand how we can scale.
Okay. Again, so that's a great question, because remote monitoring solutions can be put to great use in a couple of ways. One is that sometimes we need to know if a patient at home is going to get ill and needs to be admitted. Now, one of the challenges that we are seeing with COVID is that there is a certain degree of unawareness by the patient's own body when their oxygen level drops. So this may even happen at home. So someone who's on home quarantine may still need some degree of monitoring, either an automated device that gives an alert when things need to be checked, or they're connected to a telehealth provider that can help monitor them and take care of their needs at home and quickly refer them to a hospital setting where their services, where their care may need to be upgraded. So that is one angle, from the home quarantine, home isolation angle, where some patients will need to be monitored. The second one would be in the ICU setting or the ward setting, where the patients are already admitted and you want to protect the healthcare worker from repeated checks on them by using remote monitoring devices that can measure their oxygen levels, heart rate, blood pressure, so on and so forth, and temperature. So these are the two settings that they will come into play. The other setting that they will come into play is to decompress the ICUs. So once a patient recovers from the ICU setting, they would need to be transferred to a lower level of care. So if you look at the paper we just wrote, we've written something about a CT, which is a COVID treatment unit or a COVID care unit. That transition between an advanced level to a ward level of care can happen through multiple phases. And then again, these monitoring devices can come into play, because you can still have a patient move out of the ICU, but be monitored in a high intensity setting without giving up an ICU bed. So these are the areas where I see that a remote sensing company that has equipment that is validated and can monitor patients can actually plug into the existing ecosystem. So if you are finding out hospitals that are rapidly scaling their beds, you will need a system that is able to monitor them, connected onto the internet, and is preferentially an IoT device, and then can connect to healthcare providers so that they can function as a healthcare monitoring system.
Thank you. So we have another question from Rakesh Ranjan. While use of tech is the way forward, do you think medical staff is ready or trained to use tech platforms?
Yeah, that's a great and sobering question. See, the way we look at it is COVID, the epidemic, is somewhat of a black swan event. Yes, many people have talked about it. Authors, thinkers have always predicted over the last 10 years that a large-scale infectious calamity could be a problem. But sometimes the wake-up call in the form of a tragedy like this is what it takes to change industry. While we believe that technology is the way forward for most healthcare facilities, especially if they are resource constrained, it's hard to sometimes see the benefit for folks who are not in technology. So for example, when the healthcare industry functions, it is not apparent to them in their day-to-day functioning that technology can be a game changer. Something like this is going to uncover the flaws in the system, and that's where the value becomes more apparent. So yes, you're right that it is hard for the healthcare companies to look at it from a utilitarian perspective before they have a problem. They may not see it, but this is probably the time, if you're working in such a company devising equipments and remote monitoring equipments, this is the time to actually drive home the point that you are going to make a difference in the healthcare and the outcome of these patients. Because in these COVID units, as long as they have protective equipment, there are still practical problems. So they have gloves, their mobility is restricted. The way that they interact with these devices is restricted. It's hard to use a phone when you're working with gloved hands. So you will need these equipments that are user-friendly, designed from an infection control perspective, so that these healthcare workers are able to use your technology better. So there is an element of redesign that's required in these settings. And healthcare workers themselves, for example, there's an Italian study that looked at how many of these patients, healthcare workers, were already immune to COVID after 2 or 3 weeks of taking care of these patients. It so happened that many of them, 20 to 30% of them, were already immune and they didn't even know it. So when they tested their antibody titers, they found that they had already been infected while the epidemic was running. They were asymptomatic. Thankfully, they recovered without even any symptoms. But they were at the front lines getting infected as we speak. And this is a risk that most healthcare agencies and hospitals just can't take. We are seeing hospitals shut down just because of one case of COVID in their institution, that's a recipe for disaster.
Okay. Next question is from Chintan. He asked, how can an exposed healthcare worker be optimized to work inside COVID ICU? Is there a role of measuring antibodies of exposed healthcare workers?
Yeah, I partly addressed that because I've seen the question. So the antibody titers, if they're positive and they have met their isolation criteria, they can go back to work. But the other interesting thing is that, let's say an ICU specialist is on quarantine. They're otherwise fine. They are just sitting at home or their office because they cannot do clinical work because they're under the isolation protocol. This is exactly the time where you can capitalize on the telemedicine part. They can continue to give medical care. They can continue to take care of patients remotely while maintaining the isolation precautions and yet making sure that their skill and expertise doesn't go to waste. So an exposed healthcare worker still needs to use their skill and expertise in these pandemic settings, and that's where technology would actually make a huge difference.
All right. The next question is from Sundar Rajan. All ICU ventilator settings can be made to be displayed in an adjacent room so that the main healthcare providers need to go inside ICU only when situation demands. Innovation can be in this direction, isn't it?
That is absolutely correct. And both Tele ICUs in the US do the same thing. An expert ICU doctor remotely takes care of a bunch of all these ventilators without anyone having to step into the room. Now, the innovation that we would like to see is these ventilators need to have some sort of an online interface where you can, change the settings, and the remote doctor can change the settings. We don't yet have that, and it's probably for safety reasons. So as long as there is a safety check in place, ventilators and devices that work online as an IoT device would go a long way in handling these resource and staffing related problems. But to directly answer that question, this is already happening in India, and Tele ICU companies are doing this, and we routinely take care of ventilated patients remotely and help the bedside team manage them and make sure that they manage them at scale. So if they were able to take care of 4 or 5 ventilated patients using a Tele ICU setup, you could easily double or triple that number in a cost-effective fashion. So absolutely, that's one way to use technology.
Right. So great. Dileep, we've come to the end of questions. So is there any other points that you want to add before we conclude the session?
No, I think the questions were very insightful, and we just have to sort of understand how this time is going to stress and strain the industry. And one of the things that we foresee is that healthcare may not be the same again. Healthcare and many other industries, because of this COVID crisis, will be forced to evolve, will be forced to re-engineer things, and the style of working may change significantly, and hopefully for the better. So, I'd like to conclude with that, and just thanks for the opportunity once again. It's been a good experience.
Yeah, thank you, Dileep. And I will, with your permission, I will circulate your papers to the attendees, if that is all right with you, so
Sure.
that they can have a detailed read. And again, emphasizing the fact that these are recommendations, and the proper medical administration at your hospitals and healthcare organizations should be the final to take a call on whether these recommendations should or can be implemented. So thank you very much, Dileep, and everybody for participating. This is the first of the series we are doing as part of the COVID-19 preparedness. As we already established, there are a lot of COVID-19 positives who will not need hospitalization, but will probably be needing monitoring. And the next week's session will focus exactly on this, on how to monitor and provide home care for COVID-19 positive cases. So I will send you all the details, details of the webinar very soon over an email, and also stay connected with healthcare, with all the things that are happening with regards to healthcare from Indian School of Business on our LinkedIn page and Twitter. We are at Healthcare at ISB on LinkedIn and the same handle on Twitter. So stay connected. Please send in your suggestions for topics that you want to learn about. And we will also come back with some of the research-led insights that our faculty are doing at ISB. And then we hope to have a very good community where we can have a back and forth and then use research and training for better care delivery in the Indian context. And especially thank you for Dileep for your time, and thank you so much. And then I will all see you next week for our next webinar. Thank you.
Pleasure. Thank you. Bye.
Bye-bye.